Well, hello. My name is Mary Gwen Roper. I am both a retired pediatric endocrinologist and a woman with Turner syndrome. And I wanted to thank you for the privilege of speaking with you today about Turner syndrome. I have Madeline Lawson with me today, who is a graduate of public health, and we would like to speak with you about Turner syndrome, basically explaining what Turner syndrome is and why we feel that it is important to add to newborn screening. I will first explain Turner syndrome and why we feel that it is important to screen for as a newborn. And then Ms. Lawson will take it over from the genetic standpoint. All right, well, what is Turner syndrome? Turner syndrome is a chromosomal abnormality that results in missing one or part of one of the X chromosomes. It occurs in 1 in 2,000 live births and affects all ethnicities and nationalities. We do feel that this number might be higher because it is socially acceptable to be a cute little girl, and short stature is one of the most common things seen in Turner syndrome. So we feel it's probably more 1 in 1,800. Turner syndrome is actually the most common genetic disorder in girls, and it's important to remember there is no cure for Turner syndrome. I wanted to show this picture of this cute little girl with Turner syndrome. One, to show that outwardly, you may not even guess that a girl or a woman has Turner syndrome. Every girl with Turner syndrome is different. So it just to make the point that you might not see all of the medical issues going on with a girl with Turner syndrome. Short stature and ovarian failure are actually the two that occur in greater than 90% of those with Turner syndrome. 75% of girls with Turner syndrome fall off the growth chart by 3 to 4 years of age. The average height of an untreated woman with Turner syndrome is 4 foot 8 inches. Growth hormone therapy is the standard of care to treat growth failure in Turner syndrome and helps to augment final adult height with the help of growth hormone. Women with Turner syndrome can reach an adult height of 5 feet and above. Growth hormone also helps to preserve bone mineral density. Going on to the second most common, over 90% of girls with Turner syndrome is ovarian failure. Premature ovarian failure that occurs in well over 90%. Only about 25% of girls with Turner syndrome have any spontaneous pubertal signs. So they require hormonal replacement. Obviously, there are also fertility issues that affect the lives of women with Turner syndrome, and these girls and women should be followed by a gynecologist or a reproductive endocrinologist very closely throughout their lives. Cardiac issues occur in up to 50% of girls and women with Turner syndrome, with left-sided heart issues being the most common, and that includes bicuspid aortic valve, coarctation of the aorta or narrowing of the aorta. Also, you can have hypertension, coronary artery disease, and risk for stroke. Initial evaluation is the standard of care as a recommendation at diagnosis. Follow-up is recommended according to the most recent 2023 guidelines every 3 to 5 years for those found not to have any cardiac issues, or up to every 6 months to annually for those who do have cardiac issues. Next slide. Kidney issues occur in about a third of girls and women with Turner syndrome. And these include horseshoe kidney, duplication of the collecting system or ureters that lead from the kidney to the bladder. These issues put girls and women with Turner syndrome at risk for urinary infections and kidney disease. A renal ultrasound should be performed at diagnosis, and any kidney issues should be followed closely by a kidney specialist or a nephrologist. The next issue that I wanted to speak about is for adult women bone mineral density can be associated with Turner syndrome in a negative way. Without growth hormone and hormonal replacement working together, a girl with Turner syndrome cannot adequately build her bone bank. An experienced physician, such as an endocrinologist, should be enlisted to read DEXA scans or bone mineral density scans and to follow them closely, guiding the diagnosis of osteopenia or osteoporosis as needed. Vitamin D levels should also be checked and closely monitored. Hearing loss is another biggie. At least 60% of those women who reach their 50 and 60 years of age require some sort of augmentation to hear or hearing aids. Typically mixed sensorineural hearing loss, and a baseline hearing screening should be performed by an audiologist, and a baseline evaluation by an ENT is the standard of care. There is definitely potential progression for hearing loss with age, and this can really affect the function of women with Turner syndrome. So you can see from the 6 medical issues that I've chosen to speak about, Turner syndrome can affect pretty much any organ of the body. Treatment of Turner syndrome is obviously therefore multidisciplinary. So a primary care provider is the best person to organize and manage care. If the primary care provider is not in tune with Turner syndrome or not well educated, a pediatric endocrinologist is actually the best person to coordinate management of all subspecialties needed, including managing growth hormone, hormonal replacement, and screening for other medical issues that are associated with Turner syndrome and managing their referrals. So, managing these medical issues that are associated with Turner syndrome dramatically decreases the medical costs later on in adult life. Turner syndrome is most often diagnosed either in the prenatal or neonatal period, such as having a cystic hygroma or cardiac issue on prenatal ultrasound, or when pubertal development does not occur as an adolescent. Again, with early detection and early diagnosis, many of the medical issues associated with Turner syndrome can be adequately treated and medical costs decrease significantly. I'm going to hand it over to Ms. Lawson to go over the genetic aspects. Just to draw your attention to the right area of the screen is our healthcare checklist that also shows all of the medical issues that can be associated with Turner syndrome.
As Dr. Roper mentioned, my name is Madeline Lawson, and I have a master's in public health with a focus in maternal and child health, and I have a bachelor's in genetics. So I'm going to talk a little bit with you about the challenges of early detection for Turner syndrome. But before I do that, I do want to familiarize you all with a term you may not have heard of, even though you may be familiar with the program itself, and it's called newborn screening. So essentially what happens is pretty much every baby in the United States gets a heel prick, and that blood is used to test for treatable genetic disorders in which negative outcomes can be prevented if detected at birth. These tests use something called biochemical signals, which is basically looking at chemicals in the infant's blood to see if they have a specific genetic disorder. This creates a challenge with Turner syndrome because there's currently no biochemical signal that reliably detects Turner syndrome in newborns, which leaves us with 2 options. The first option is a karyotype, and the second option is finding gene doses of SHOX, VAMP7, and SRY using something called quantitative polymerase chain reaction. But I'll go into more details about that in just a moment. A karyotype is essentially a picture of chromosomes when they're frozen at a certain moment in DNA replication, in which you can count all the chromosomes that are present in a cell. This allows you to detect Turner syndrome because you can see, as in the case in the picture on the right, if an infant only has one X chromosome and no Y chromosome, or if there's really any chromosomal abnormality. One benefit to including karyotypes into newborn screening panels would be that I can detect all chromosomal abnormalities, not just Turner syndrome. However, the cost can be very high. You cannot use dried blood on this test, and a typical newborn screening panel will use dried blood on a spot card. Our other option includes gene doses of SHOX, VAMP7, and SRY. So I'll go into more details on how this works, but I want to briefly discuss the study that provides validity to potentially using this method moving forward. So the study being used took place in Mexico and had approximately 5,000 females and 5,000 males. In this study, they used quantitative polymerase chain reaction, or qPCR. So basically, this is like when you're printing many, many, many thousands and millions of copies of DNA. So this eventually results in you receiving a certain gene dose at the end of the qPCR process. As we'll see in the picture in a second, the amounts of genes that you get at the end of this process can tell you what's present on a certain chromosome. But what you need to know for now is that you can detect Turner syndrome by looking at the SHOX gene and the VAMP7 gene, which are found on the X chromosome, and then the SRY gene, which is found on the Y chromosome. Essentially, what happens is that you can put blood samples onto filter paper, so you can use dried blood with this technique, which goes along with current existing testing. You conduct PCR, so you make those millions of copies. And then, depending on your results, you can figure out what's going on with a child if they have a sex chromosome abnormality. In the case of Turner syndrome, since they're missing an X chromosome, they would have less gene dose of the SHOX gene in the VAMP7 gene. And there would be no SRY gene because there's no Y chromosome present. In a normal child, you would just expect to see normal amounts. There wouldn't be any loss or any gain. One other benefit to this test, and referencing back to the study, is that the reason that they included males is because using these three genes and three gene doses allows for detection of all sex chromosome aneuploidies, which is a great benefit. As far as the effectiveness of this test in detecting Turner syndrome and sex chromosome aneuploidies in general, we can see that it is highly specific, highly sensitive, and it has a high positive predictive value and a high negative predictive value. So essentially, it's saying that this test will tell you if a child does have a sex chromosome aneuploidy, and it won't misdiagnose a child with a sex chromosome aneuploidy either, for the most part. Now, some benefits, as I'd been referencing earlier, but I'm just going to list them out now, is that you can use dried blood samples. This means you can use the traditional heel prick test used in other newborn screening tests. You can screen for all sex chromosome aneuploidies. However, since this would be a little bit of a newer test, the cost may vary. However, there are a variety of different techniques and methods that you could use to potentially lower costs and make it more feasible. Currently, there are studies going on in the United States that want to detect Turner syndrome in newborns using genome-wide association studies. And while that's great, if the technology doesn't get there, we have children going undiagnosed with a very common genetic disorder for no reason when we do have technology that can be implemented more cheaply, more effectively, and potentially more quickly. So, on that note, we would just like to thank you for your time and remind you that newborns with Turner syndrome can't wait for that extra help. They need the protection for their hearing, for their bone health, for their growth, all other major organ systems. Conducting this testing can save a life and help people figure out what is going on with their child as opposed to wasting years looking for answers. If you have any questions about anything we've discussed today, please feel free to contact me or Dr. Roper using our emails below. Even if you're not interested in learning more about prenatal screening, we're happy to provide resources and information if you happen to know anybody personally impacted by Turner syndrome. Thank you.
Thank you.